Okay, Dr. Mwalaji Lawal.
Hello,
we can start now.
Yeah, please, let's start.
Okay, we can start now.
They will join, the others will join us along the way. By the time we finish with the preliminaries, more people will join.
Okay, sir.
I think we can start, yes.
Okay, sir. Okay, sir. Good afternoon, distinguished pediatricians. I want to formally welcome you to the second presentation in our series. Today we'll be talking on, the topic will be on SLE. And we're fortunate to have two for the price of one, if you allow me to say that, because we have two distinguished pediatricians who will be representing Lifeline Children's Hospital in making this presentation today. And they are Dr. Njokama, who is, she has an interest in neonatology and nephrology, as well as Dr. Okore, who has an interest in allergy, as well as asthma management. We want to thank the management of Lifeline Children's Hospital for allowing two eminent pediatricians to make this presentation to us today. But before they present, I would like Dr. Mwalaji Lawal to say one or two words, and then we can take it from there. Thank you very much, Dr. Mwalaji Lawal.
Okay, yeah. Thank you very much, Dr. Eletu. I welcome everyone to this second meeting. In particular, those who are joining the group for the first time. The last time we met, we were 65. Now our membership has grown to 75. So we are really growing, and I'm very pleased about that. I will have to repost my welcome address to the platform after this meeting to bring us all up to date with what has happened before we joined. We have been working hard, the coordinators, Dr. Eletu, Dr. Akinwumi, Dr. Fajulu, Dr. Orode Duati, Silverline Nwizu, and Dr. Odudu, to bring these meetings to your for you to participate in. We need your cooperation, everyone, by volunteering to make presentations. And in that regard, I want to commend the Lifeline group for coming up, for volunteering to make today's presentation. Also, there are still many pediatricians in private practice who are not in this group yet. So if you know of any, kindly reach out to them so that they can join. We need ideas from everyone. This group belongs to all of us now. And we need ideas from everyone on how we can make the group add more value to all members of the group. We have a vision of letting this hour that we spend together, let it become the best hour that every pediatrician in private practice will spend in the entire month. And it is possible through our contributions. So please, we are welcome to your ideas. You can call me or send me a message, or any of the coordinators I've mentioned, or the advisors. I thank those who have been in contact with me, giving suggestions and ideas about how we can make things better here. Dr. Onifade, Dr. Esangbedo, Dr. Grange, Dr. Ajeni Fuja, for their continuing interest in giving ideas. When we get more ideas from other people, we will distill them at the coordinators level, and we present them to the group for us to adopt. For example, issues are coming up about, the scope of the membership. Should we open it up to residents and even more people in the tertiary centers, even trainees or medical officers working in pediatric departments in private hospitals, because these are the people that we leave the patients with when we go home. These suggestions are coming up. Let's ponder over them. Also, suggestions are coming up about, okay, in order to ensure that we are all up to scratch on this platform, should we begin to sponsor other professional training courses for everyone, and should we make them mandatory or voluntary or voluntarily mandatory, as the case may be, you know. But all the same, I think we're on a very good start, and these ideas are coming in. Please, let's have more of these ideas. We shall distill them, and if there are any ideas that will make us to do better, we definitely will introduce them and adopt them. Today's topic is a very interesting one, and the fact that you use Conundrum to describe it tells me that we are in for a very interesting time. You know, so I really can't wait. You know, I thank Dr. Njokama and Dr. Okore for volunteering to present, and I'm happy that the big masquerades at Lifeline are also somewhere behind to throw in their weight at the appropriate time. Lupus, the word itself is a Latin word for wolf, while the erythema is a Greek word for redness. So the lupus erythematosus itself is confusion, because the rash was thought to resemble the bite of a wolf, but in reality, it looks more like a butterfly. So I wish there was a Latin word for butterfly. It will more aptly describe it as a butterfly red rash, but it's called lupus because it was first observed by the first people who observed it to be similar to wolf bites. So confusion resides in lupus erythematosus, and I'm sure you will educate us more today. I hope you will not worsen the confusion after today's presentation, but I look forward to it, and at the same time, I welcome everyone. Thank you very much.
Thank you very much, sir. So Dr. Njokama and Dr. Okore, over to you.
Thank you very much. Good afternoon, everyone. I want to thank the chairman and the chief coordinator of this program for giving us the opportunity to share our clinical experiences with a very great mind. I am Rukeme Njokama, a consultant pediatrician at Lifeline Children's Hospital, with special interest in hematology and nephrology. And with me is Dr. Okore, and together we'll be presenting the conundrum of Sle. I'll be taking the case presentation while she'll be doing justice to the literature. We chose this topic because it's an uncommon presentation, and at the initial stages of this presentation of the child, it was a diagnostic dilemma. I present to you CU, a 16-year-old boy who came accompanied by his mother with complaints that this child had been ill for 5 months and she did not know what was wrong with him. So the mother, after the series of events, decided to bring her child to Lifeline Children's Hospital. The complaints were recurrent sore throat, recurrent fever, joint pains, all of 5 months duration, episodes of pallor of 4 months duration, generalized body swelling of 3 weeks duration, and a skin rash of 2 weeks duration. Sorry, I'm having to challenge moving my slides. The initial symptom was that of a sore throat. He had several episodes, and the first few episodes were treated with only strepsils. He had several episodes of fever at about the same time the sore throat developed. They were transiently relieved by antipyretics, And the last episode of fever was a day prior to presentation. And this was one of the reasons that necessitated their presentation at Lifeline Children's Hospital. At about the same time, he had fleeting joint pains that involved both large and small joints. The pain was described as dull, but severe enough to restrict his daily activities. The pain was sometimes relieved by paracetamol. A month into the illness, this child developed pallor, and it progressively worsened to the point where he needed blood transfusion, and this was just a week prior to presentation. 3 weeks before he presented, he had body swelling, which was generalized, started as a pedal edema, and later developed ascites and periorbital swellings. He also reported that he had a nodular rash, which mainly was around the elbows. And this was quite confusing because of the location of the rash. At the onset of his illness, he was diagnosed to have acute rheumatic fever and was placed on a single dose of benzyl penicillin intravenously and oral prednisolone. As the illness progressed, with no clear-cut diagnosis, the parents took this child to 2 other hospitals and after taking them to 2 other hospitals, there was still a diagnostic dilemma, and the parents continued with their concern, and so decided to bring this child to us at Lifeline Children's Hospital after 5 months of the illness. On examination, we saw a 16-year-old boy who had a dull appearance. He was weak, pale, afebrile, anecteric, well-hydrated, not cyanosed, had no pedal or facial swellings. His weight was 60 kilograms, and his height was 175.2 centimeters, which were normal. The body surface area was 1.7 per meter square. The throat examination was normal. The tympanic membranes were normal bilaterally. The skin was grossly normal. There were no joint swellings and no tenderness elicited in any area of his joints. He was breathing calmly with a respiratory rate of 18 cycles per minute, and his oxygen saturation was 98% in room air. The central nervous system was normal. His pulses were normal. The blood pressure was also normal with 120/70 millimeters of mercury. But as we go along, you would see what happened to his blood pressure. No murmurs were heard. He had a distended abdomen with demonstrable ascites. He had a provisional diagnosis of acute rheumatic fever. The reasons were because of the sore throat, which was poorly treated, the presence of fever, joint pains, and the nodular rash which this child described. We also considered that could this child have had a chronic kidney disease? And the reasons for these thoughts were, again, because of the sore throat that was poorly treated. Could it have led to a glomerulonephritis that has now developed to a chronic kidney disease? He had generalized body swellings, he had pallor, and the duration of illness before coming to us was 5 months. So these were the reasons we entertained this diagnosis. However, over the next couple of days, while we reviewed this child, on further questioning, he described that on exposure, when he comes outdoors, he experiences some bumps on his skin that are usually itchy. And that was when we started thinking, could this be a photosensitive rash? And we considered systemic lupus erythematosus. We decided to investigate this child along our diagnostic considerations. We did a gram stain, which revealed that there was a gram-positive cocci on his throat swab, and the culture yielded growth of group A streptococcus. The anti-streptolysin O and anti-streptococcal DNase B were normal. His urinalysis showed a nephritic picture with massive proteinuria and hematuria, also had leukocyte esterase in the urine. The microscopy revealed white cells and red cells, which are in excess of what is normal, and the presence of granular casts. The culture of the urine, however, yielded no growth. He was anemic with a hematocrit of 24.9%. His platelet count was just at the lower border of what is considered normal. The total white blood cell and the differentials were all within normal limits. His potassium was approaching upper limits of normal. He had acidosis. He had markedly elevated urea and creatinine, and his calculated GFR was 52 mils per minute per 1.73 meters squared. His calcium was low, and he had hypoalbuminemia. Considering the massive proteinuria he was having, I mean, this is expected. So if we look at the urinalysis and the electrolytes done, it tells us that we were dealing with significant renal impairment in this child. Complement factors C3 and C4 were markedly reduced. The antibody to double-stranded DNAs was positive. The anti-nuclear antibody was positive. Rheumatoid factor was within normal range, had elevated ESR and elevated CRP. These findings are strongly in keeping with SLE. And so we felt this child, we're confident at this point, this child SLE with renal impairment. He had mild aortic and mitral regurgitation, mild pulmonary hypertension, mild dilatation and hypertrophy of the left ventricle, trace pericardial effusion, and good biventricular function on echocardiogram. The ECG was normal. Hepatosplenomegaly and minimal ascites was seen on ultrasonography, and the renal biopsy, which we planned to do and prepared for, could not be done due to travel restrictions, as this patient presented to us at the peak of the COVID pandemic. We treated this child for SLE with renal impairment and was placed on methylprednisolone intravenously for 3 days, thereafter converted to oral high-dose prednisolone. He was also on mycophenolate mofetyl hydroxychloroquine, amlodipine, hydrochlorothiazide, because he became hypertensive at this point. Calcium and vitamin D was added to the treatment as their adjunct medications for patients with SLE. He was on omeprazole because of the high-dose steroids to prevent ulcers, and also on antibiotics. We monitored his blood pressure very closely. His urine, his weight, and abdominal girth were measured daily and monitored daily. He had alternate day electrolyte, urea, and creatinine done, and we maintained a very strict input and output charts. This table shows us the patient's clinical course. If you look at the first row, it shows you the pre-treatment, and the very last row, the 4th month into treatment. So I'll take it row by row. The pre-treatment, we see that his blood pressure had risen from 120/70 to 140/90 millimeters of mercury. His weight was 60. He had this nephritic picture on urinalysis. He was pale. The urea and creatinine were markedly elevated. On the 3rd day into treatment, we see that the parameters were still high. Blood pressure was rising, the weight was rising, and his urea creatinine kept on rising really high. And this tells us that the illness was still evolving, and the medications hadn't taken full effect. On the 11th day into treatment, however, we begin to see a decline in his blood pressure, a decline in the weight. The protein and blood in urine had reduced to 2+. The hematocrit had improved to 28%, and we see that the urea and creatinine, though high, but was remarkably low compared to the 8th day before. 3rd week into treatment, blood pressure was coming down, the blood and protein in urine was coming down, the urea creatinine were also on a downward trend. And 4th month into his treatment, blood pressure was normal. The weight was 51 kg, he had just 1+ of protein in urine. His hematocrit had gone up to 32.4%. His urea and creatinine and potassium were satisfactory. Furthermore, at his progress, we see that the ESR, which was initially 120, had dropped to 30. On the 4th month into treatment, CRP had dropped to 10 from 107 pre-treatment. The antibody to double-stranded DNA was now negative. The C3 and C4 levels, which were reduced, were now within normal. Interestingly, a year into treatment, which was just about 2 months ago, his ESR was 10, and the C3, C4 levels are still within normal ranges. Don't know if anyone is asking why SLE in this patient, and this slide tells us why. Child met both the clinical and immunological criteria for SLE. In summary, I have presented to you an adolescent boy, ill for 5 months, multi-systemic presentation, several hospital admissions. Indeed, this was a conundrum. But with detailed questioning, careful and close examination and monitoring, and extensive laboratory workup, we could comfortably say this child had SLE with lupus nephritis. He was started on treatment, he initiated remission on steroids and MMF, and he's currently on maintenance medications. He still is in remission and attends regular clinic follow-up visits. Dr. Okori will continue from here and we'll be discussing the literature. Thank you very much.
Oh, I'm sorry, I didn't realize I was still muted. Thank you, Rukeme, for a very lucid presentation. My name is Dr. Amalachukwu Okori. Good afternoon, everyone. I'm here to continue the conversation on SLE, a conundrum, and I'll be taking us through the rest of the conversation. We'll be talking about the clinical features, clinical features and how to manage a patient with SLE. Rukeme, please, can you stop sharing your slides? Oh, thank you. So, systemic lupus erythematosus is a systemic autoimmune rheumatic disease characterized by autoantibodies directed against self-antigens, leading to immune complex formation, immune dysregulation, and ultimately resulting in damage to essentially any organ. So in essence, SLE is like the body fighting against itself. It has protean manifestations, which means it can manifest as anything literally, and must be considered in the differential diagnosis of many conditions. Hello, can you hear me?
Slideshow. Clearly.
Okay, sorry. Okay. And must be considered in many conditions, including PUO, arthralgia, anemia, psychosis, or even fatigue. First description dates back to the 13th century. It was Rogerus named the disease using the Latin word for wolf because the manifestations were similar to that of a wolf bite. Specific causes of SLE remain undefined. However, research suggests factors including genetics is being found to be more common in African Americans and Asians. Hormones is being found to be commoner in females, and environment. Sunlight and drugs could affect people that have a predisposition to SLE, and complement deficiencies. An interesting twist to the etiology of SLE is the hygiene hypothesis. Now, hygiene hypothesis up until now had been associated with the asthma and allergy. So Strachan in 1989 brought up the hygiene hypothesis and postulated that with increase in hygiene, there was an incidental increase in allergic disorders. This same finding has been linked to SLE. And why is this? It was found that for African Americans in the United States and other developed nations, the incidence of SLE was higher in them. However, they have the same genetic makeup as we Africans in Africa, in West Africa, but we don't have as many cases of SLE. So in a research by Michael Edwards et al., they were trying to find out why was this? These people have the same genetic makeup, but they have the prevalence of SLE was higher in those in developed countries. The hygiene hypothesis came up again. They did a research and studied diet and microbes in pathogenesis of lupus, and alluded the fact that lupus was lower in those in West Africa because of the increased hygiene of the African Americans in the Western world. It was also thought that the more excessive use of antibiotics those in the Western world affected the gut microbiota and predisposed them to being at higher risk of developing SLE than those of us that are still back here in Nigeria. I think that's one good reason to be happy that we're still back home. The epidemiology of lupus. The incidence in the US is about less than 15 years, about 0.5 to 0.6 per 1,000, and is more in Native Americans and Asian Americans. African American children may be up to 60% of the patients, and male to female ratio is about 1 to 4 before puberty. So it's usually higher in females. However, our index patient was a male child, and the other patient we had in Lifeline that had SLE as well was a pre-adolescent male, an adolescent male, was about 10 years of age as well. It's uncommon in children less than 8. In a study in Southwest Nigeria, specifically Lasus, by Adelawar et al., showed a male to female ratio of 1:2. And the first documented case of lupus nephritis in Southeast Nigeria was by Odetunde et al. One of the authors of that article is on this call with us, Dr. Okafor. I present Cephalic Ma, she's my teacher. Edward et al. Of OAU also reported a case of a 13-year-old girl with a 4-month history of intermittent cough, fever, weight loss, and chest pain. I was referred to OAU as a possible case of tuberculosis, having been managed in peripheral hospitals for 4 months. This again brings to the fore the fact that diagnosing SLE is indeed a dilemma. In our patients, the patient had been seen in peripheral hospitals for 5 months, and this patient as well has a 4-month history. And also in the study done in Lasus, they found out that patients had between 1 to 3 years before a conclusive diagnosis was made. So we find that, it's obvious that making a diagnosis of SLE requires a high index of suspicion and is typically not for the untrained physician to make. A diagnosis of SLE in this patient in OAU was made after her demise, 19 days after admission. So in summary, to easily remember the pathophysiology of SLE, what happens? Increased production of autoantibodies, including anti-DNA antibodies, immune complex formation, leading to immune complex deposition in tissues and tissue damage. And this process causes severe inflammatory injuries. I think this is very easy for us to remember. Autoantibodies, immune complex formation binding in tissues, severe inflammatory injuries. This is in summary what causes SLE. There's a global loss of self-tolerance. There's autoactivation of autoreactivity and B cells, and generalized tissue injury. Why is diagnosing SLE? Why do we say this is a conundrum? A conundrum is essentially a dilemma, a difficult problem to solve, and SLE captures the meaning of a conundrum. The manifestations are protean, and it's been called the Great Masquerader, a name that was previously used for syphilis, which is another disease that affects multiple organ systems. It's a rare disease associated with significant morbidity and mortality, especially in children. One of the significant differences in adult and pediatric SLE is that pediatric SLE is very more aggressive and readily affects the organ systems quicker than adult SLE. It mimics several differential diagnoses. So SLE is one of those diagnoses in a clinical exam that you're not sure what is wrong with your patient. It's safe to say, I believe the patient has SLE, sir. And then you can drive the conversation that way. There are no validated diagnostic criteria. Now, what do I mean by this? The anti-neutrophil antibodies for diagnosing SLE is about between 95 to 100% sensitive, but only about 85% specific. So it can be positive, and that doesn't mean that the patient has SLE. It has to be supported by the other extractable nuclear antigens. By this, I mean the anti-double-stranded DNA, anti-Smith, anti-Rowe, the complement deficiencies, before you can put all this together to make a diagnosis. I mean, the fact that you have to do all this to make a diagnosis is already telling us that SLE is a disease that comes at a high cost to the patient. It requires a very high index of suspicion to make a diagnosis. So clinical features, we've emphasized before that the manifestation is protean and multisystemic. The features include a rash. The malar rash is typical, occurs in both cheeks and spares the nasolabial folds. We need to keep that in mind. It's erythematosus. There's arthritis, arthralgia, myositis, pruritus, pericarditis, hemolytic anemia. Now, hemolytic anemia, we had the second patient we had in Lifeline with SLE, a 10-year-old male child, presented to us with recurrent episodes of unexplained anemia and headaches. And we screened this child, did all the tests. We couldn't really find out why he kept on having unexplained anemia until the mother gave us a history that she was on treatment for, she was on follow-up for SLE. And then we screened the child for SLE and the results came back positive. There's also lymphadenopathy, hepatosplenomegaly, chronic abdominal pain, seizures, psychosis, stroke. So ultimately, this disease affects every system. So this is a picture of the malar rash. I also included this in black skin so that we're able to appreciate some of these lesions are not very easy to appreciate in black skin. We see that the nasolabial folds are spared in both pictures. This is a picture of the discoid rash, both in dark and clear skin. We see that these lesions are more circumscribed and a bit raised. This is a mnemonic, the SOBRAIN MD. This is one of those mnemonics that we used to cram in medical school. I remember the first time I heard it, I thought the doctor was very intelligent. This is something that helps us remember SLE in a nutshell. S for serositis, oral ulcers, arthritis, photosensitivity, the blood picture, renal, antinuclear antibodies, the immunologic picture, neurologic, and then the malar and the discoid rash. So if we can just keep this image in our heads and have a diagnostic challenge, if you can run through this briefly in your mind to help you know, am I dealing with an SLE or not? This is a diagrammatic representation of what happens in SLE. So we see that every organ system in the body can be affected by this disease. So how do we make a diagnosis of SLE? 11 criteria from the American College of Rheumatology are used for the classification of lupus, and basically the same criteria are used for children, and any 4 criteria are sufficient for classification. ANA is almost always present, but is not diagnostic of SLE. So what are these diagnostic criteria? 11 of them: the malar rash, nasolabial ulcers, photosensitive rash, the discoid rash, arthritis, pruritus, pericarditis, proteinuria greater than 500 milligrams per DL, or evidence of nephritis in urinalysis, hemolytic anemia, thrombocytopenia, leukopenia, seizure, psychosis, a positive ANA, and positive anti-double-stranded DNA, anti-Smith or anti-phospholipid. The SLICC, the Systemic Lupus International Collaborative Clinics, published a modification of the ACR criteria and said that lupus patients should meet 4 criteria with at least 1 clinical and 1 immunologic criteria. And they could also have biopsy-proven nephritis in association with a positive ANA and anti-double-stranded DNA. So the introduction the introduction of the immunologic criteria was done to show the new findings that lupus also has an immunologic basis to it. So these are the immunologic criteria: elevated ANA, elevated anti-double-stranded DNA, positive anti-Smith, positive anti-phospholipid, low complement, or positive direct proof test in the absence of a hemolytic anemia. So why SLE in our patient? We've seen this table before. It's just a reminder. Our patient had the rash, the arthritis, the pericarditis, the proteinuria, the anemia, and the immunologic criteria of ANA above laboratory range and low complement. How do you manage a child with SLE? So the key components in managing this patient: prompt diagnosis. We can't overemphasize the importance of having a high index of suspicion when you're making a diagnosis, when you're faced with a possible SLE. You must think far and think wide and think beyond the regular malaria and typhoid that most people think of first. Managing SLE is a multidisciplinary approach. So everybody on the team is involved: pediatrician, pediatric cardiologist, nephrologist, neurologist, ophthalmology, dermatology, the nurses, social workers, clinical psychologists, and the family's parish priest may even be part of this team, because there's a lot of psychological and social support that is needed for this patient. The goal of therapy is to control the manifestations. It's a chronic and lifelong illness, so there is no cure. But however, the flares, which are the seasonal increases in the manifestations, can be controlled, allowing a child to have a good quality of life and preventing serious organ damage. Follow-up must be long-term and committed. Laboratory workup, the complete blood count. We've seen that they can have anemias, they can have thrombocytopenia. Their electrolytes, we've seen that they can have electrolyte derangement because of the kidney damage. The CRP or ESR. However, CRP and ESR is typically advised. We're going to see the reason why in the next slide, because it helps to distinguish between a flare and a superimposed infection. Then the ANA, anti-double-stranded DNA, anti-Smith, the extractable nuclear antibodies, antigens should be done. Lupus anticoagulants, complement C3, which should be reduced. Adjunctive investigations may be things like pulmonary function tests, because the disease can affect the lungs, cognitive function testing, chest X-ray, renal ultrasound, and MRI of the brain. And this is because of the other organs that could be affected by this disease. How do you treat a child with SLE? Anti-malarial agents, hydroxychloroquine, is usually the first line. If this fails, steroidal anti-inflammatory, prednisolone, methylprednisolone may be used. Non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, can be used also to control the symptoms. Then the immunosuppressants, cyclophosphamide, azathioprine, MMF, mycophenolate, mofetil are also used. For serious flares, the patient may need 1 or 2 courses of intravenous immunoglobulin. Then the biologic agents, rituximab and belimumab, may also be used. Vitamin D and calcium are used as adjunctive treatments because of the side effects of chronic steroid use. Steroid can cause osteoporosis, so you need to protect the bones while treating this patient. Other adjunctive care, vaccination against encapsulated organisms. So we've seen that SLE also has an immunologic basis, so it's important to make sure that these children are protected against organisms that can possibly harm them. And also the effect of the drugs like steroids can suppress their immunity. Avoidance of sun exposures, the use of sunscreen when they're outside. Psychosocial support for the patient and the family, as this is a life-altering diagnosis, not just for the patient, but also for the family. Complications of SLE could be from the illness or from the treatment of the illness. One of the most frightening complications is the macrophage activation syndrome, which is a rare but life-threatening complication in which the patient may have liver insufficiency, coagulopathy, pancytopenias. It looks like sepsis and can lead to DIC, our systemic inflammation, and rapidly can progress to fatality. There's retinopathy and optic nerve disease, nephritis, vasculitis, atherosclerosis, behavioral disorders, osteoporosis, and all the other complications of long-term steroid use, which we know. How do you follow up a child that has SLE? Regular growth monitoring is very important, especially when the diagnosis is made in younger children. Our patient was 16, but if you're making this diagnosis in younger children, their growth must be monitored, their weight, their height, because the drugs and the disease process itself can affect this. They must have annual eye examinations. They must have intermittent hospital visits between 3 to 6 months. You need to check their blood pressure, do their urinalysis, liver function tests, and their blood work, electrolytes, and full blood count. The ESR should be paired with the CRP to distinguish a flare from an infection. So if you have a child with a normal elevated ESR and a normal CRP, it's likely that the child is having a flare. However, if the ESR and the CRP are elevated, the child most likely has an infection superimposed on the SLE itself. Intermittent anti-double-stranded DNA and complement level checks may help to be early pointers to a flare. So when you check this, when the child comes for follow-up and they're elevated, it may help you take precautionary measures or be on the lookout for a possible flare. A very critical part of the follow-up of this child is that the coordinating pediatrician must always be on the same page with every other clinician. So we've seen that this child will have multiple referrals. So there's a huge care pathway for this child. This child is going to be seeing the eye doctors, the dermatologist, the rheumatologist. The central pediatrician must make sure that they're backward referrals. So he's getting a feedback from all the people you refer this patient to. And you must be on point with this. This is not the patient you refer and then you forget to get a feedback to know how to continue managing the patient. So this is one of those cases where collaboration is key and coordination is also very key to make sure that our patient, gets the best possible care that, he or she can get. The SLE Disease Activity Index, the SLEDI, and British Isles Lupus Assessment Group Index are also monitoring tools which help in the follow-up of such patients. So if you have, these are tools you can download online that tell you what to look out for at each point that the patient comes for follow-up. The adolescent SLE patient should be trained for self-management. Like we've said, this is a disease, a chronic disease. So as this child is getting into adolescence, knowing fully well the challenges that come with puberty and peer pressure, those of us that have patients that manage like sickle cell patients and diabetics know that this adolescent phase is a critical phase in their management. This is the phase where they don't want to take their drugs. This is the phase where they start wondering why they're different from other children and why they have to be taking medication and other people are not doing that. So a lot of counseling and empathy has to go in when this child gets to the adolescent phase. You must train, you must encourage, and you must give the child hope and make sure that the child understands his symptoms and when he's going to have a flare to make sure that his quality of life is optimized. Intermittently, quality of life assessment tools must be administered to track the patient's progress. I'm going to show a sample of this quality of life assessment tool. However, what it just does is to ask the child questions around how SLE affects his daily life. So do you think that this SLE is slowing you down academically? In fact, while I was preparing for this, it was eye-opening to see that they were concerned about so many things, including whether they could kiss people or be in romantic relationships with people because of this disease. So their quality of life is significantly affected. And so we as clinicians should not just be satisfied with asking, are you taking your drugs? Are you doing your medicine? Are you doing your blood test? We must find out how is this affecting the child's quality of life and what we can do to support the child in any way possible. These tools, the quality of life assessment tools ask questions across mental, physical, and social functioning. An example is the smiley. Hello? An example is the smiley. Simple impact.
Write it there.
An example of this is the smiley.
Your name,
the simple.
Your office and your phone number.
Sorry, please. Can we please mute our microphones? An example of this is the smiley.
Kindly mute yourself if you're not presenting. Thank you.
An example of this is the smiley, the simple measure of impact of lupus erythematosus in youngsters. Is something we can administer to them to help monitor them. Transiting to adult clinics is another sore point in the managing of these patients. Yet again, we see this occurring in other chronic illnesses like DM or sickle cell. We know how difficult it is to migrate these patients to adult clinics. They always come back complaining. The adult physicians are not kind. They're not empathetic. The same thing happens to patients with SLE. And it's been found that a lot of them drop off from follow-up at this point of transiting to adult clinics. So it's important that the coordinating pediatrician tries to ensure a seamless transfer to the adult clinics to make sure that all the progress made in managing this child is not lost. So this is a sample of the quality of life assessment tool I had earlier talked about. So it's asking the child questions about how does your SLE rule your life? I worry that I hold others back. I feel like a prisoner in my own home. I feel older than my years. So you just ask these questions and assess how the child pictures his illness, and you are better able to counsel and equip the child mentally to handle this disease. Can SLE be prevented? This is a very tall order, but there's new information on possible things that could be done to prevent SLE. So there's research ongoing. I found this research very interesting. It was done by M.Y. Choi et al. So what they did in this research was they had a cohort of patients that had a positive ANA that could be an incidental finding or found out during screening that they did for patients that had a family history or other predisposing factors to having SLE. So these patients were screened intermittently. So they will bring them in, do their ANA, and do their anti-double-stranded DNA and monitor them over a period of time. Now, doing this made them pick up patients that had preclinical lupus before progressing to incomplete lupus or clinical lupus. So when screening and they find patients that have a positive ANA and positive anti-double-stranded DNA, they follow them up intermittently, monitoring for the earliest signs of clinical disease. Some were placed on hydroxychloroquine, and this helped to slow progression to clinical disease. However, in this same research, they also questioned the economic implications of taking this as a standard practice. Obviously, we know that in environments like ours, this cannot work, but it's important for us to know that people are working to see if there are ways of prevention. So this is something that you can offer to families that you know that, okay, they have a family history of somebody that has lupus. You can offer them screening that can we monitor your parameters over a period of time just to see that, you know, if anything is going to happen to any member of your family, we're able to pick it up on time. So it's important that we know this. I found this quite interesting. Flares can also be prevented. Sun exposures can be avoided. Exposure to ill people, we've seen that SLE affects the immunity of the patient. So it's important to stay away from people that have that are ill or have viral illnesses that, you know, around, keep them away from you. Can also avoid stressors like surgery, pregnancy. 5-year survival rates approach 100%, 10 years close to 90%. But I must say that these disease outcomes are for people in the developed countries. For us, we really don't have studies as regards disease outcomes, but I think it's very easy to, you know, disease outcome in our own environment, I don't think it will be up to 100% because of the challenges we have in managing this disease. Early mortality is predicted by rapid progression to end-stage renal disease, childhood onset cardiovascular disease, male sex, and low socioeconomic status for obvious reasons. We've made it clear from our conversation that managing this disease is very capital intensive. So low socioeconomic status is very easy for them to fall off the radar. What are the possible challenges in managing SLE in our own environment? Number one will be the cost of care. This is a chronic illness. The lab investigations required are expensive. The drugs for treatment are expensive, and we have poor penetrance of health insurance. So the huge costs of managing this is something that would eat into the finances of any family, no matter how established the family is. So this is a very big challenge. And again, we also need to remember that most of the patients that are going, before they get to a center where this diagnosis has been made, they've spent their money treating severe malaria and resistant malaria in other peripheral hospitals. So by the time they are coming to you, they're already depleted, the little reserve they have is already depleted, and then you have to deal with managing this patient against the background of very limited finances. So this is a huge problem in our environment. The second challenge is the human capital. SLE managing SLE, like we said, is collaborative work. A clearly established care pathway has to be made for this child, in which every subspecialty is involved. Now, in our own environment, where there's a human capital flight, establishing this kind of care pathway may be very difficult. There are some places where you make the diagnosis and the patient has to travel to the next stage to see a nephrologist and maybe the next stage to see an ophthalmologist. And this obviously is going to impact on the quality of life of the patient and their commitment to caring for a child that has this disease. And then it also, Another challenge we could have is having strong referral systems. There is no reason why a patient is with you for 4 months and you're not making headway, and then you're not referring. This is very important for those of us that are in private practice. We need to know that referral is honorable. It doesn't take anything from you if you don't have the skill set to manage a patient and you escalate on time, or you bring it to a forum like this forum where we can put heads together and make a headway as regarding the diagnosis of this patient. There's no need holding on to a patient if you're not sure of what is going on. Referral is honorable and does not mean that you as a clinician are not good enough. So we need to encourage early referral or early inviting, collaborating with other clinicians to improve the outcomes of our patients. And then the lack of social support, this is huge. This is not a diagnosis that a family can manage alone. So they need support groups, they need government support. And all this is not very easy to get in an environment. So with these few points of mine, I hope I've succeeded in clearing the conundrum of systemic lupus, making us understand that this diagnosis is indeed very difficult to make. Referral is key, and collaboration is something that we must keep on emphasizing, and so that at the end of the day, our patient has the best quality, best possible care. I want to acknowledge my senior colleagues, Dr. Kudaya, Dr. Harold Shodipo, and Dr. Onifade, who are a very important part of preparing for this presentation. Thank you very much.
Thank you very, very much. Dr. Fajulu. Dr. Fajulu.
Yes, I'm here.
Please take over. Thank you very much to the two presenters. And there is a question in the chat box, please. Thank you.
Thank you very much. Thank you, Dr. Eletu. I want to say a very big thank you to Drs. Njokama and Dr. Okore for the excellent presentations and trying to clear the air about this SLE, which they say is a conundrum. So we're on to the question and answer session. And there's a question already in the chat box. It's from Professor Adenike Grade. Good afternoon, Prof. So she says, a very good presentation. And her question is that, is the growth potential of the child compromised in any way? So I think Dr. Okore will be to answer that, or any of the two presenters.
Rukem, I think you should answer that question, please.
Thank you very much for listening to us. The growth of a child is can be affected largely by the treatment we use for systemic lupus erythematosus. So these patients are on high-dose steroids. They are also on immunosuppressive agents, and both of them have a significant effect on the growth of the child. So imagine a child is on steroids and on a drug like a cyclophosphamide. It definitely will affect the child's weight, the height, and it definitely will affect the growth potential. Yes, madam.
Okay, thank you for that. Please, can you put your questions in the chat box or raise your hand if you want to ask a question? Okay, Dr. Uzodima, your hand is raised. Can you unmute yourself and ask your question, please?
Thank you, Dr. Fajolu. First of all, to thank the presenter. Presentation. My name is Dr. Uzodima, Founding Medical Director of Esr Children's Hospital and Pediatric Cardiologist. I'm listening to this presentation on SLE. There are two questions that linger in my mind, and one of them is, you mentioned that you wanted to do a renal biopsy at some point, which you eventually could not do. What exactly is the role of renal biopsy, management of this patient, and after the renal function tests have returned to normal, is there still an indication for renal biopsy? That's number one. Number two is you also presented that the child had trace pericardial effusion on one of the echoes. Have you done a follow-up on that pericardial effusion to know whether that pericardial effusion has resolved or not? Once again, I want to thank you for a very beautiful and very articulated presentation. Thank you.
Do you have any other question for Dr. Arthur?
No.
Thank you very
any
much.
of the presenters can answer.
Thank you very much for the question. Please, can you hear me?
Yes, we can hear you. Go ahead.
Thank you very much for the question you asked. Renal biopsy is crucial, actually plays a crucial role when you're suspecting there's a lupus nephritis. That is based on your urinalysis or from your electrolyte results. If you suspect there's a renal involvement, the role of the biopsy, renal biopsy, is crucial. The reasons are it enables you to classify this patient into the various classes, as the different classes actually have different management approaches. For instance, the class 1, which is the minimal change, may not necessarily require immunomodulators. You can treat a class 1 patient with just steroids. Okay, so it helps you in classifying the patient into the different classes, enables you to know the class you're dealing with, which can determine the management approach, and it can also help you in communicating the patient or determining the clinical cause or outcome of this patient. A repeat renal biopsy in a patient who had an initial one, so that's the second question now. A repeat renal biopsy in a patient who had an initial one sometimes is advocated if there are signs that show that the nephritic picture is persisting even after treatment. So you have started, if you know the patient has, from your renal biopsy, you have classified the patient and you have started on a particular treatment, and there's still persistent proteinuria, hematuria, and derangement in your creatinine levels. It's an indication for a repeat renal biopsy. So in those instances, yes, you can repeat it, you do a renal biopsy. The question on the echocardiogram, the patient had been scheduled earlier in the year for a repeat echocardiogram, but they haven't done it. He resumed school early this year, was able to resume his school early this year, and is currently running a kind of a crash program because he's in his final year in school and has not been able to do a repeat echocardiogram, but it has been scheduled.
Okay, thank you. Thank you very much, Dr. Njokama, for that. I can't see any more questions in the chat box, neither can I see anybody's hands raised. But I have a question, I think, to Dr. Okore. I'm not sure if you'll be able to answer that, but the study that he said is ongoing, identifying children or people who have a family history and starting them early on hydrochloroquine. Is there any information or evidence to say that when you start early, that you can prevent the inflammation and all the problems that lead on to all the signs and symptoms that we see with SLE? Because majority of the times, by the time they get to us, they've already have a renal compromise and People are managing them as nephritic, nephrotic. I remember the first case I saw as a resident, the child presented with this nephritic picture. The next time nephrotic, then she came again, it was nephritic, and then the malarash. Then I was in Presbyterian unit then, and the malarash was what gave up the diagnosis. So this hydrochloroquine starting early, also considering the long-term side effects of the drugs, without the child having any symptoms, starting early. Is there any known beneficial benefits of starting these drugs early?
Okay, thank you for your question, Ma. So yes, among the cohort of people they studied, I can't remember how many, they said that they found out that starting the hydroxychloroquine delayed the progression. So they categorized the patients as preclinical lupus, which for the preclinical stage were people that have positive ANA, positive anti-double stranded DNA, but had no signs of lupus. And then this other group was the incomplete lupus. So maybe they have a rash, just a rash, or they just have skin changes, but nothing else. So they said that for the people they started hydroxychloroquine for, it delayed their progression to clinical lupus. Okay. So there is some benefits, but however, I think that before we do this, we need to be sure that the benefits will obviously outweigh the risks of the drug itself.
Thank you very much. I don't see any more questions, so I think it's safe for me to say that the presenters have done an excellent work in clearing the air about lupus and reminding us about this condition, rare as it is, but with its own difficulties when it comes to making the diagnosis, and of course, management and the long course of the disease itself has its own problems, even when it talk about the financial aspect and the psychological aspects of the disease. I don't know if there's anybody who else. I can't see any other hands raised up. No more questions in the chat box. So I think we can put this question and answer session to a close, and I'll hand over to Dr. Eletu to continue. Thank you.
Thank you very much, Erythi. I'm sure we've all had a very good time today. Dr. Can I hand over?
Okay, good afternoon once again, everyone. It's been a very stimulating conversation as well as the presentations. I'd like to thank Dr. Mobolaji Lawal for initiating this group and chairing it. I also would like to thank Dr. Eletu and Dr. Odudu for working behind the scenes, along with Dr. Fajolu. Other members of the coordinating group include Dr. Silverline and Dr. Dorothy, myself. I thank you very much for making it happen each time and very well put together. It's our joy to thank Lifeline Children's Hospital Management for running the kind of practice that will take on this kind of case and giving permission for it to be presented. We also thank Dr. Rukeme Njokama and Dr. Amalachuku Okore for taking on this presentation and doing an excellent job of it. A very articulate presentation, each one made. And thank you very much for unveiling this masquerade that is systemic lupus erythematosus in children. I believe all of us will now have a higher index of suspicion as we see patients. And on behalf of the group and myself, I would like to thank all participants for taking out the time to attend, especially those who asked questions, which is proof that everybody paid attention and followed the presentation. Thank you very much for staying on to the end. We thank our advisors who are present and all those who joined from diaspora. Thank you so very much. Thank you for taking out time. We hope to see you next time and hope that one of you, one of us, is going to volunteer for the next few, and that we actually have a lineup of exciting presentations. Thank you everyone once again, and I hope you do have a good day.
Thank you very much. Thank you.
Thank you very much. Hope to see you on the 26th of August. Bye for now.
Bye-bye.
Thank you very much.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Thank you. Bye-bye. Bye-bye.
Bye-bye, everyone.
Bye. Bye.
Thank you.
Bye-bye.
Thank you. Bye. Bye.
Thank you very much. Okay, bye-bye.
Bye. Bye-bye.
Bye, everyone. Well
Bye-bye.
done, Lifeline. Dr. Kudaya, well done.
Hi from London. This is Dr.
Ladies,
Howard.
thank you.
Well done,
Thank
everybody.
you. Thank you,
Well done,
Dr. Njokama and Dr. Thank you very much. And Dr. Okori. Thank you, Dr. Uzodima. God bless you.
Well
Thank
done,
you.
my yes,
Thank you,
ma'am.
Dr.
Bye-bye.
Mobolaji Lawal.
Amalachuku. This is Dr. Onifade
Dr.
from the
Elitu.
UK.
Yes,
Thank you.
we
We're proud
can
of
see
you.
you. We can see you.
We are so proud of
from
you. Thank
London,
you
too.
very much.
Dr. Shodipo is from London. Yes.
Yeah.
So
Okay.
London. Thank
So
you.
nice to see all of you, and
Shodipo
thank
from
you
London.
so much.
And I'm
This
next door to you guys now.
Oh, okay.
I'm
brilliant.
on holiday, so I'm not
Thank
far
you
from
very
you.
much, Dr. Mobolaji Lawal. We appreciate
Thank you.
you.
Thank you very much. To you.
And our mama, Professor Grange, we appreciate you.
Thank you. Thank you very much.
Thank you very much.
Also, Uzodima, thank you so much.
Lifeline, make una go now.
Yes, ma'am. Bye-bye, ma'am.
You don't come in. Bye-bye.
Make una go now, like
Bye.
Lifeline.
Bye-bye. I'm going. Bye-bye. Once I
Okay,
go,
sure.
everybody goes.
Thank you very much.
Bye. Thank you, Dr. Mobolaji Lawal.
Bye.
Thank you.
See
Bye.
you.
Bye-bye.
Okay. Fumbo.
Hey, Yabo. Well done. Right. This chat's where's the